We had some exciting results at ESOC 2023 in this regard. The first was the uncertainty regarding the timing of resuming anticoagulation or initiating anticoagulation in patients that have ischemic stroke due to atrial fibrillation. The concern, of course, or the competing risks and benefits being that if you restart too early, you may increase the risk of hemorrhagic transformation of the infarct versus if you restart too late, you'll end up having higher risk of ischemic stroke. At present, kind of one of the most widely used algorithms that is kind of affectionately termed the Dina Rules is this 3-6-12 algorithm, or 1-3-6-12 algorithm, where if someone has essentially a TIA or has an ischemic stroke, but their symptoms have resolved, you can resume them on day one, or start anticoagulation on day one. If it's a small stroke, day 3, moderate size stroke, day 6, and if it's a large stroke, day 12. And of course, there's various kind of variability in those exact dates, or days from symptom onset, but they're various derivatives of the same concept. And then there was the Elan trial that was presented at ESOC, where essentially it was shown that if you start minor or moderate strokes at 48 hours or large strokes at 6 to 7 days post-event, relative to kind of later anticoagulation, which roughly coincided with that 3-6-12 rule that I just mentioned, that there is a suggestion of an overall net benefit in that you had a reduction in ischemic stroke with the earlier timing of anticoagulation without any excess risk of a major and in particular intracranial hemorrhage, which is of greatest concern. So I think that's very exciting in that we're likely going to be initiating anticoagulation sooner in patients with AF on the basis of these results. Another important trial that was presented that has yet to be published is the Arcadia Trial, where the use of Apixaban versus aspirin in patients that had embolic strokes of undetermined source and evidence of atrial cardiopathy. And these patients were randomized to standard dosing of Apixaban versus aspirin. And the trial was stopped early at interim analysis due to futility. Although there was no excess risk of bleeding with Apixaban versus aspirin in this population, there was also no suggestion of any benefit for ischemic stroke reduction. This is a very important finding for several reasons. First is that we anticipate a large proportion of this population would have brief durations of AF on long-term cardiac monitoring. So not only does it answer this question in patients that met these particular atrial cardiopathy criteria that we use in the Arcadia trial, but it also adds further support to the fact that we cannot just assume that anticoagulation is beneficial for stroke prevention in patients that have brief duration AF on long-term cardiac monitoring. The evidence that supports the use of anticoagulation in patients with AF comes from trials that were performed before long-term cardiac monitors became widely used. So the proportion of patients with paroxysmal AF was small in those trials, and the paroxysmal AF was very different in those trials versus the paroxysmal AF that we're capturing now. In those studies, the paroxysmal AF was found on ECGs or Holter monitors, and thus the burden of AF was much greater in those paroxysmal AF cat subgroups than the ones that we're encountering in practice now. So I think the ramifications of Arcadia are not only important for this subgroup or the trial that was the trial population, but also has very important implications for the need for future studies in comparing anticoagulation versus no anticoagulation in patients with brief duration AF. And it is supported by the earlier ATTICUS trial, which also compared Apixaban versus aspirin in patients that had predictors of AF, and 25% of that population did have AF detected during study participation. And that also showed no benefit of Apixaban versus aspirin, albeit it was a smaller trial. So one is it answers the population that was studied. Two is it raises very important questions for the management of brief duration AF. And then third, it raises questions about the future of ESUS, not only as a construct, but also in terms of their treatment. So some believe that on the basis of these negative results, we should abandon the ESUS construct and really start looking at even more detailed phenotyping of subtypes in ESUS. My own personal view and that of others is actually the opposite, in that one of the major criticisms of the ESUS construct when it was first produced, and especially after the negative Navigate ESUS and Respect ESUS trials, was that obviously, this is a heterogeneous population with different stroke mechanisms, and it doesn't make sense to test them all together within one trial. However, we've now done the alternative. We've more carefully phenotyped ESUS in the ATTICUS and Arcadia trials, and we still haven't seen benefit. So it seems, at least thus far, that more careful phenotyping hasn't resulted in any different results than the original Navigate ESUS and Respect studies. So then my question is that, does this actually mean that it's the construct that's the issue, but rather could it be that it's the treatment that we've been using that's made the issue? And in particular, if you look at ESUS populations, some studies would demonstrate that up to 70% of them will have multiple competing sources. So they'll have evidence of a cardiopathy and atherosclerotic disease, right? And I think personally, a dual pathway inhibition may be the way forward for ESUS, and that combining an anticoagulant with a antiplatelet agent, similar to what we discussed earlier in the COMPASS trial, as well as what we're doing in OCEANIC-STROKE, will be the key to help these patients. And fortunately, we expect a large proportion of patients that enter OCEANIC-STROKE to have ESUS, and we would be able to further support this hypothesis through subgroup analyses of that trial. And then lastly, for anticoagulation, actually maybe two more points, I guess. Another is the efficacy of dual pathway inhibition in patients with atherosclerotic disease. So combining a low-dose anticoagulant plus an antiplatelet agent for people who have athero. And there's another trial that's ongoing, FDA-funded study that's ongoing in the US, and we're about to expand in Canada. And that's the Captiva trial, where there's 3 arms being tested in patients that have significant intracranial atherosclerotic disease, one of them being the COMPASS regimen of a low-dose vascular dosing with Apixaban 2.5 milligrams twice daily plus aspirin. And then the last thing is going to be the use of anticoagulants in patients who have had bleeding in the brain. Intracranial hemorrhage has been an exclusion criteria for trials that have proven the efficacy of anticoagulation in patients with AF. There are now several phase 3 trials that are ongoing, looking at anticoagulation versus avoidance of anticoagulation in patients with AF who have survived an ICH. One of them is the ENRICH-AF trial that we're leading at PHRI, and we hope, at least in the ENRICH-AF trial, to have some significant answers in the coming year to be able to address that dilemma.